Thank you everyone for joining us for this month's SSAT Mentor of the Month video. We are very excited and privileged to have Dr. Jason Hawksworth coming to us from MedStar Georgetown University Hospital. He is the Chief of Robotic Surgery at MedStar Georgetown, and his background is quite impressive. He is a graduate of United States Military Academy, West Point, and Dr. Hawksworth has served in 3 combat tours in Afghanistan on a forward surgical team. He earned his medical degree from Wake Forest Bowman Gray School of Medicine and completed his internship and residency at Walter Reed Army Medical Center. He completed his fellowship in hepatobiliary and multi-organ transplant surgery at MedStar Georgetown Hospital, and we are very excited to talk about robotic HPB program. It's an exciting field for everyone that does HPB and as well as general surgery. So thank you so much for joining us and spending time with us.
Thank you very much for the invitation, and I'm honored to be here, and hopefully this is productive and insightful for other viewers.
Great. So just to kind of start us off, just so the audience can kind of understand a little bit more about you behind just being a surgeon and things like that, can you kind of give the listeners what initially attracted you to the field of medicine and specifically subsequent transplant and HPB?
Sure. So I went to West Point because I wanted to be an engineer, and that changed at some point during college, and I ended up majoring in life sciences, which is kind of the pre-med track at West Point, and went into medicine. And then I really fell in love with surgery in medical school and went into general surgery residency, where I was initially attracted to transplant because I thought the research was very fascinating. And I did a research year in Alan Kirk's old immunology lab, which was great. And as it turns out, I don't really do much translational research, if any at all. I'm mostly a clinician, and I do some clinical research. But that's what kind of brought me into the field. And I still think that the transplant and hepatobiliary research is fascinating, but it's not in the cards for me, as it turned out.
Excellent. Well, great. And then what are some of your hobbies when you're not doing transplants or robot surgery and doing all that you do?
Well, I think my former self had a lot more hobbies. I was an avid runner, and I really enjoyed photography. And now I think I spend most of my time outside of the hospital doing kid activities. We have 3 kids,
Yeah.
and apparently I'm a video editor now, which I guess is sort of related to photography. Um, so that's sort of a hobby now, I guess. And I've been known to play some PlayStation here and there. Um, I use it as an excuse to hone my robotic skills.
Yeah. Those go hand in hand, supposedly, right? For those of you who haven't seen Dr. Hawksworth's YouTube video, I find that hard to believe, but I'm sure you've all appreciated his YouTube videos that he have graciously uploaded, so we can all watch his amazing work there. So moving on to really this piece of the robotic HPV program, can you kind of let us know, how did you start getting into robotics? Like, was it part of your fellowship, or is it something that you decided to start after training as an attending? Because I know there's different trainings throughout the country, and some have a robotic heavy training, some don't. And so is it for everyone? Can you get into it later on? So can you tell us what your road was to robotic surgery?
Sure. So I'm one of those attendings who kind of grew up without the robot. Laparoscopy was an important part of our training, but there was no robotics anything when I trained. And then I went to a big open, kind of hard-hitting transplant and hepatobiliary fellowship, which was kind of the norm then, and it's still fairly the norm, I would say, for the most part. Robotics and minimally invasive surgery are still kind of breaking into our fields. Um, and I spent, the first 5 years of my practice was mostly related to transplant, learning liver transplant, doing organ procurements and whatnot. And that was kind of the first half of my practice. And then I became the laparoscopic hepatobiliary surgeon at Georgetown. So I did all of the laparoscopic distal pancreatectomies and minor hepatectomies. And that was kind of the beginning of my minimally invasive niche. And then about 3 years ago, I started doing robotics. So I grandfathered in where I did the track for people who didn't come out of training with a certificate. So that's an animal lab and some simulation and proctored cases and a couple case observations. But I brought, 8+ years of open hepatobiliary and transplant surgery experience, and then 5 or so years of laparoscopic experience to robotics, and I had that kind of background and experience when I started doing robotics, and that made it a lot easier, I think, to make the transition, and I think made it more successful.
It's quite humbling to know that you've only started this robotics 3 years ago, and you're having these videos that you're making, which is crazy to me. But that's amazing. Can you describe the process it took you to kind of start building up the robotic program you have now? Like, what were the? Can you talk us through like the initial beginnings? Did you get early buy-in from leadership, or did you take a lot of convincing, or how did that look like?
So a little of both. My boss, if you will, at Georgetown, kind of let me sort of play with the robot, and wasn't really a believer in it, I don't think. And so it took some convincing, and really convincing through successful patient outcomes is kind of how I got a lot of buy-in over time. And in that process, I have great partners at Georgetown, so we shared a lot of cases, and usually, more than one attending in the room for a lot of these complex hepatobiliary robotic cases, especially at the beginning. And even now, if I'm doing a hard case or one of my partners is doing a hard case, we tend to make sure that there's another attending available, just to make sure everything goes well. And worst case scenario, if there's a need for conversion, you have good help in the room, to make sure that the patient has a good outcome. So that was kind of the first thing, is the leadership buy-in, which I think is different at different places. If you're in an environment where the leadership is already looking to delve into robotics, I think that makes it a little easier. If you're in a place where there's a lot of sort of naysayers, which is probably more common,
Right.
even now, I think that it takes some convincing. You want to have a good partner to help you get started, and kind of keep your leadership updated. You certainly want to have the leadership's back if something doesn't go
Right.
well. You want to have that top cover. So the leadership buy-in is very important. And then as far as preparing to start a robotics program, there's a larger community now, I think, of robotic hepatobiliary and transplant surgeons out there, and I think most of us are very good with networking and helping people start and be successful. And there's a lot of really good robotic surgeons who are always available for phone calls, emails, questions. As you know, a lot of us put our content out on social media to try to help others. I think seeing it helps a lot. Once you've seen it, that it can be done, that helps you mentally be able to,
Yeah, thank you for doing
take
that, by
on
the
these
way.
cases. So
I love your
I
videos.
think,
I gotta say, I'm a big fan.
for me, like I didn't even think a robotic right hepatectomy was possible. For me, it was just like science fiction until I saw John Martini down in Charlotte, North Carolina, do one, and then I realized that it was very doable. So I think that really helps to see other people do it, and know that there's other people out there doing it. I think it helps a lot, to convince yourself to take it on.
Right.
Um, and there's other things. Building a team, having a good robotic team is really important, because you're at the console. You need to have reliable help at the bedside. Um, Ideally, a first assist or a PA or something equivalent that can troubleshoot the robotic arms, change your instruments quickly. That's really important. We also have really good fellows and residents at Georgetown, so that helps a lot with the instrument changes. And as you know, for the hepatectomies, I have a bedside surgeon run the CUSA, the laparoscopic CUSA, to cut the liver. So you really need a skilled bedside surgeon to do that. That's usually our fellows. Um, and then, as I said, we always have another attending for the major liver cases so that they can take over if needed.
Perfect.
So the team is really important, I think. And then there's a lot of other little things that you don't really think about until you have to. For example, block time is important so that you can consistently get on the robot and maintain that skill set. You don't want to do one robot case every 6 weeks. It's not enough. You should try to do at least one a week, especially if you're doing complex cases.
Yeah.
So that requires some working with the block committee or however it works at your hospital, um, to get that set up and kind of announcing, if you will, to the hospital that you're going to do this and get all the moving parts in place so that you can be successful.
Perfect. And if you don't mind, can you share with us some early pitfalls or struggles that you faced that you can recall when you're starting up?
Yeah, so there's no shortage of pitfalls in in doing this, and I think that's true with in just the nature of our field, to begin with. The cases are complex. The diseases are very difficult. So even when you're doing open cases, there's lots of pitfalls and problems that you have to deal with, and I think that can be exacerbated with the robotic approach, but also mitigated as well. I think that the robotic approach has a lot of advantages as well. Once you kind of get used to it and build your skill set and whatnot. Um, so I think early pitfalls would be kind of patient selection and case selection are really important when you're starting out. So what I did is I initially picked cases that I knew I could already do laparoscopically. So worst case scenario, if I got stuck robotically, I could finish the case laparoscopically. So distal pancreatectomies and minor hepatectomies. Left lateral hepatectomy is a perfect case to start robotically because you know that you can do that very reliably laparoscopically already. So those are good examples. I did a lot of general surgery starting out, so cholecystectomies and the cirrhotic patients. Um, I went to the hepatologist and asked for all the cirrhotic gallbladder cases, so did all those. And then I went to the post-transplant nurse practitioners, asked for all the hernias, the post-transplant hernias, and did all of those robotically. So those are good, kind of easier cases to get started. And then start building into your practice the harder cases of the major hepatectomies. And a good way to approach those is kind of tell yourself and tell the patient that you're going to start robotically, and get as far as you can robotically with the idea that you could convert if something's not going right. And I think most patients are okay with that, if you talk to them,
Great.
in a kind of honest way. And the first robotic right hepatectomy I did, that's exactly what my approach was. And I kind of had a plan to at least do the hilar dissection robotically and maybe mobilize the liver robotically and then convert for the parenchymal transection. And that's what I told the patient, and then ended up doing the whole thing robotically,
Oh, wow.
and was very sort of pleasantly surprised that I was able to do that. And that patient did great. So that's a good way to start. I think you just have to be kind of, don't be too, I don't know, hasty or aggressive. Just kind of take your time and be careful you don't want to have a big disaster as
Yeah.
one of your first robotic cases. That'll just set you back like a year. So be smart about that. And then, I think that there's a lot of things that come up robotically that are hard to anticipate. Um, so port placement is totally different robotically than it is laparoscopically. Positioning can be different. The approach, so for example, when I was doing laparoscopic distal pancreatectomies, I would put the patient up on their side, and I would do the kind of lateral to medial approach,
Mhm.
where you mobilize the splenic flexure and kind of come around medially. But robotically, I put the patient supine and I do more of a medial to lateral approach. That's different. Um, so I think the approach robotically is a little bit different, and I think more analogous to how you would do these cases open, which is one thing that I really like about the robot, is that you can really approach these cases almost the same way that you would open,
All right.
and you can work through the case similar to the way you would do open because the instruments articulate and you have the 3D optics, so you can suture more more closely to the way you would open. Whereas I always felt like I was a terrible laparoscopic suturer. Um, I always felt like a medical student suturing for the first time ever when I had to sew something laparoscopically.
Yeah.
Whereas with the robot, it's closer. It's slower than you would open, obviously, but it's much closer and more precise, and it looks better and works better.
Right.
Um,
No, but it's a
I,
good
I
point
think
you
that
made
answered the
about
question.
the setting the expectation with the patients about starting robotically, but understanding that there's a chance of converting to open, so they don't wake up and like, oh, what's that big incision for? So that's like a very good point.
Right.
So another thing is if you can kind of let us know what you thought as a advantage of robotics as compared to laparoscopic as you switched over that you've noticed in the past.
So one of the reasons I switched to the robot from laparoscopy is I kind of hit a wall in the case complexity. So I could do laparoscopic distal pancreatectomies, minor hepatectomies, some biliary cases, but there were cases I just couldn't get through laparoscopically. So for example, um, a laparoscopic hepaticojejunostomy was something that I just couldn't do safely and adequately. Certainly not as good as I could do that anastomosis open. And as you know, that's a unforgiving anastomosis if it's not right. The patient has a lot of long-term problems, short-term and potential long-term problems. So that's a good example. And then major hepatectomy, I just couldn't get through the hilar dissection laparoscopically. I never felt safe dealing with bleeding laparoscopically. So those are examples of cases that I really couldn't do laparoscopically, and certainly there's people out there that can. Um, I think there are some laparoscopic gurus with very advanced laparoscopic skill sets that can get through those cases just fine. But I do think that that's the minority of surgeons, and one of the things that robotics allows is the sort of widespread application of minimally invasive surgery to more surgeons. Um, and and that was a big reason. Another reason is our field is very competitive, right? And there's lots of surgeons out there that say they can, do these cases laparoscopically, but I think patients more and more are seeking out robotic surgeons. So certainly there's a competitive and marketing aspect to robotics that can't be ignored for sure. So those are some of the reasons I switched from laparoscopy to robotics.
Great. So what advice do you have for people like me who want to start getting into robotic HPB program and those else listening on the program, like as somebody who's really had a very successful program within a very short period of time, what early advice do you have for those people?
So we talked about leadership buy-in. That's really important. I think finding a good partner um, to kind of work together through the cases, but also have someone to kind of strategize and talk about the cases before and after. I think that's really important. Um, Building a team is, like we talked about, is really critical, I think, especially when you start doing the harder cases. Um, and then, you know, there are other things. One big thing that, you know, is really important is kind of doing your homework. You know, so before I would do a case that I hadn't done before robotically, I would try to do a case observation. So, and intuitive is really good about facilitating that. So going to see a surgeon who does that case frequently and watching them, picking their brain, taking notes, um, that's really beneficial, I think, before doing a case that you haven't done. And then I probably watched like 1,000 hours of other people's videos on YouTube and whatnot, really to kind of get a feel for port placement and positioning and tricks and pitfalls. I think that's something that we have available now that at least when I was in training, it was really hard to find video footage
Right.
of
Yeah.
surgery,
Yeah.
and you really relied on your attendings and your different rotations to see how things are done and take notes and study it, and obviously textbooks just don't do these cases justice, especially when you're talking about hepatectomies, pancreatectomies. You really cannot learn that in a textbook. You have to see it and do it and live it. Um, so I think it's a different world now. You can find a lot of really good content online, not only for the cases but also just, for example, understanding the 3D anatomy of the liver. For me as a resident, I just really struggled doing that. And I don't think it was until I was a fellow that I started to understand 3D anatomy of the liver. And now they have, software and programs and models where you can really see and understand that. So it's a lot easier, I think, for this generation of surgeons,
Mhm.
and I think the learning curve will be a lot shorter, for the newer surgeons coming up.
Excellent. So that's a nice bridging point to education, robotics, and the residents and fellows. So, what advice do you have on managing a resident who comes to your case and their expectations of, do they get to do part of the case? Do they do bedside? Do you have a graduated program? Like, how do you set the expectation depending on what level resident comes to you, and just how do you enter that?
So I think this is probably one of the hardest things right now with advanced robotics is how do you train the next generation, right? And
Right.
we're kind of in this weird in between space where a lot of us are either learning robotics ourselves or still on the learning curve, or maybe just getting over that learning curve. And so, at what point can you really start training, fellows and residents? And I think that's a very difficult problem for the hepatobiliary and transplant community. And there are some centers that have been very successful in training. Pittsburgh comes to mind. I mentioned John Martini in Charlotte. He has a dedicated 1 year robotic HEV fellowship that he offers to fellows who have already completed another hepatobiliary, usually open hepatobiliary fellowship, and so already kind of understand the disease and know the anatomy and can do the cases open, and then he offers the 1 year um, fellowship for robotics, and I think that's probably a good model, um, for now. But it's a really difficult educational paradigm. Is how do you train um, fellows residents to do these complex cases? So I feel like I'm past my learning curve for a lot of the cases that I do. There are still some cases where I definitely I'm still on the learning curve. So for example, the total pancreatectomies and auto islet transplants that we do, I still struggle with those, and some of the complex hepatectomies. I really just don't feel like I can adequately train anybody when I still feel like sometimes I can barely get through those cases myself.
Exactly.
Um, but I think, some of the cases, so the distal pancreatectomies are great teaching cases. And for example, at Georgetown, we typically have a third year resident on service and then we have a fellow. So I'll have the third year fellow open the lesser sac, kind of do the initial port placement, dissection, exposure, and then I'll have the fellow, depending on their skill level, mobilize the pancreas. I usually do the vessel dissection myself, unless the fellow is really skilled robotically, and some of the senior fellows have been able to do that part. And then I'll usually divide the pancreas and the vessels, and then have the fellow do the completion pancreatectomy and splenectomy, and kind of finish up the case. And I think that's a good way to kind of
Yeah.
parse out the different aspects of the case. Everybody gets to do something,
Hmm.
not just bedside.
Yeah.
So that's a good example. The major hepatectomies that I'm doing robotically, usually I have the fellow run the CUSA, so they're at the bedside for most of the case. I think eventually, I'll have the fellow do some of the hilar dissection robotically, and then go to the bedside and cut the liver, or I'll go to the bedside and cut the liver with the CUSA, and they'll stay at the console. But it really kind of depends on the case, the skill level of the fellow, and then probably most importantly, the experience and comfort level of the attending.
Right.
Um, we're also training some of our own attendings on these cases, and so who gets priority? The attending, who's going to be the next educator in a few years, or the fellow. So it's kind of as I said, it's sort of a weird in between period, where really probably the fellows that have trained at Georgetown over the last couple of years have gotten a really great exposure to robotics, and are competent with general surgery certainly, and then some of the minor hepatobiliary cases. But I think it'll be a few years before we're able to really train fellows and have them come out of the fellowship competent on some of the bigger cases.
Right.
So certainly a challenge for the community, um, and I think it'll take a few years to kind of sort that out, honestly.
Perfect. And last question is, how much do you think robotic training is needed in general for general surgery training? Like, do you think this is the next universal thing like laparoscopy, or do you think this is going to be isolated specialty center training?
So I think that robotics is laparoscopy. It's just the next generation of laparoscopy. So I really don't see it as a separate, a separate thing, like a lot of people do. I think that, as the technology gets cheaper, a big part of that is the intuitive patents expired a couple years ago,
Mhm.
I think. So there's more competitors on the market, which will certainly drive the price down for robotics. And I think eventually, you know, laparoscopy as we know it now will be just sort of phased out, and everything will have a robotic component. So I think that it's definitely the future. Technology always wins when you're talking about these kind of things.
Yeah.
So I foresee in 10 years, there won't, laparoscopy as we know it now won't exist. I think most minimally invasive surgery will be robotic to some extent. And maybe the degree of technology that you need to do certain cases will vary, right? You don't need, spectacular advanced technology to do, diagnostic laparoscopy and appendectomy and cholecystectomy, but you do need advanced technology to do, like the cases that we do, for example, or cardiac cases, thoracic cases. So there'll probably be a spectrum of technology available, and you can use it as you see fit for the cases, as appropriate. Um, and I just don't see it going away. For our field, for hepatobiliary and transplant surgery, I really think that almost every pancreatectomy and hepatectomy can and will be done robotically in the future, with the exception being very large tumors, multi-organ surgery, certain types of vascular resections or complex biliary. That'll be a little bit of a stretch maybe to do all of those robotically. But I think that most will be done robotically. Another good example is something, just a year ago, the whole concept of doing a kidney transplant robotically, I thought was pretty silly, even as someone who does minimally invasive surgery. And now I routinely do kidney transplants robotically. I do think there's an advantage in some patients and some body habituses. I do think that there's an advantage of doing those cases minimally invasively. And I also think that as the technology improves, those will be much easier minimally invasively and probably become mainstream at some point, I would imagine.
Oh, great. Well, uh, thank you, Dr. Hawksworth, for really spending time with us and really giving us your insight. It's been very helpful. I really think it's amazing that in the short period of time you really, have built up a robust robotics program at Georgetown. And thank you for uploading all the videos that you do on YouTube, because I know it has definitely inspired me, and I know it has inspired others who have watched the video. And I look forward to visiting you at Georgetown and watching some cases live. But again, thank you on behalf of the SSAT Mentor of the Month, Dr. Jason Hawksworth. I appreciate so much your time.
Absolutely. Thank you very much.